Good evening, everyone. As we welcome you all once again for the series, the web series of TB guidelines, what we are going like we're conducting since last 2 Thursdays, and this is the third Thursday, I suppose. So the first series or the first episode was all about the background and the framework of the guideline making, that is PMDT 2021. Followed by then we went into diagnostics of radiological part as well as the microbiological confirmation, which was being conducted by Dr. Jankaria sir and Dr. Camilla Rodriguez madam. So after confirmation, and now we are moving ahead after diagnostics. Now we are moving ahead. Before going to treatment part, let us just cover something about prevention. As prevention, as we all know that prevention is better than cure, right? So yes, guideline has also managed to make some space for TPT, that is tuberculosis preventive treatment. And for the same today, we have an eminent panelist over here. We have Dr. Padmapriya madam, who has joined over here right now. And the entire session today will be moderated and will be taken care by none other than the multi-talented, the most multi-talented person I ever know, Dr. Salil Bendre sir, who is not only a chest physician, but also an artist, a painter, a singer, a mimicry artist, a fantastic mimicry artist, and also a magician. Yes. Sir, I think I have forgotten many of your qualities. Sorry for this. But you can just take over the entire session, sir. It's all yours.
So thank you, Vikas. That was very overwhelming. Thank you so much for that introduction. And first of all, greetings from Mumbai to all the listeners. And thank you for CCI, Dr. Krishna and his entire team who have been regularly conducting these wonderful programs and helping spread academics all over India, and I can say even for the world, because these are all Zoom meeting. Anyone, anywhere, sitting anywhere can always hear them and replay them again and again. So with that, we will talk today of the most important topic which we are discussing is about tuberculosis. Today being World Tuberculosis Day, and I congratulate all the hospital doctors, the healthcare workers, professionals, consultants who are with us today and who are not able to connect today, every one of them, for continuing this fight against the onslaught of tuberculosis, MDR-TB, XDR-TB, and different problems related to tuberculosis. Before I just go on with that, I should thank Vikas for inviting me today for this discussion with all these eminent panelists. And we will have a wonderful talk, debate, you can call it fight, argument, discussion, whatever best word you can think about. So without further delay, I'll just introduce our eminent panelists for today, starting from Dr. Padmapriyadarshini ma'am. She would be blogging with us. She's already with us. So she's the director of ICMR, the National Institute for Research in Tuberculosis. And she has completed a short-term fellowship in HIV from University of California, LA, PhD in pediatrics from the Dr. MGR University, Chennai. She's been a principal investigator for multiple national, international projects. And she's a part of what is the most important aspect for us, a part of the national guidelines for management of extrapulmonary tuberculosis, as well as the introduction of bedaquiline in the patients in India. She's also a Senate member of the Tamil Nadu Dr. MGR Medical University, Chennai. So I'm thankful that she spared her time with us to enlighten us a little bit more on this particular topic. I will just introduce all of them right now so that later on we have just an academic discussion. Dr. Radha Munje, ma'am, she is a senior faculty. Everyone knows her very well. She is the professor and head of the IGGMC Medical College, Nagpur, Chest Medicine. Member of the Governing Council of Indian Chest Society. I can see she's very busy, but again, she's made time for us.
But even she's boarding the flight.
She's also boarding the flight. So this is going to be somewhere on the flight and somewhere some people on the ground. So member of the Governing Council, Indian Chess Society, recipient of the Dr. S.N. Tripathi Oration 2015 Lucknow, and she was the organizing chairperson of the 73rd NatCon. She's been the firefighter for tuberculosis in all through, right from our problems of sensitive TB as well as resistant forms of TB. So I welcome her as well. We have Vikas, none other than Vikas, I should say. He's like the firebrand, always the ambassador, the National NTEP trainer for tuberculosis, chairperson of the DPS Shatabdi Municipal Hospital, member of the National Technical Expert Group for NTP in India, which is I feel proud to say that from Mumbai, he is representing us in the National Technical Expert Team, and he's contributed in making the national PMDT guidelines for DRTB. So, because nice of you to have us, and your words will also be very valuable for us. Amita would be joining in, I suppose. Maybe she's there already, but Amita Nene is very, very well known amongst the entire faculty of CCI, the members of CCI. She's always been into the academics, heading the Department of Pulmonary Medicine, Bombay Hospital, authored more than 50 publications, having authored more than 12 chapters in textbooks of respiratory medicine. And of course, she's been the West Zone chairperson of the Thoracic Endoscopic Society of India, as well as she's a member of the governing body of the Indian Chest Society. We'll meet her again, of course, in NAPCON, in the coming NAPCON, to attend her sessions. Dr. Ravi Dosi is here, highlighting Indore, the leading pulmonologist from Indore, who is spreading knowledge in his simple forms of videos and making tuberculosis and explanation simple for the patients. He is the CCI National Secretary. So this entire team is with us, who are going to talk about and discuss, and I'm going to be just a listener. I had asked Vikas, should I be the moderator, the mediator, or the meditator? So I will try to meditate today, just listen to everyone, starting from Dr. Padmapriyadarshini ma'am. I will call her Priyadarshini ma'am, that's small to take her name. And I would, yeah, ma'am. So, ma'am, just to start off the discussion, I would request you to please tell our listeners in detail as much as possible about the TMT, the Tuberculosis Preventive TPT strategy, and how it is going to be enrolled and what are the pros and cons of this strategy. So, ma'am, I would like to request you to please take the mic and speak. Thank you. Is she?
Yeah, she's there.
Yeah, okay.
Needs to unmute, I think.
Padma ma'am, are you there in the panel right now?
I can't see her on the screen. Can you people see her?
Hey, she is there.
No,
she was there.
She's back. Ma'am, Priyadarshini ma'am, please unmute.
Actually, both of ma'ams are boarding flights right now. That is Dr. Raja Munje madam and Dr. Padmapriya madam coming back from Delhi, Vidyan Bhavan to their hometown now.
Right.
So I think that's the reason they are finding it a bit difficult to connect. Dr. Padmapriya ma'am, are you able to listen to us?
But we need them both badly because they are supporting this TPT, or they are trying to explain about its utility. So I definitely need them on the panel. But Vikas, can you till they join, can you just give us some background?
Dr. Ravi will take care of it.
Sure. I am for it, so I will speak about it. Basically, the fourth pillar of what is new in this NTP program, that is prevention. So that is why a strong emphasis has been now given by the government of India on contact tracing, and not only tracing those contacts, but even treating those contacts in a totalitarian way. That means they will be following those patients, the close contacts of the family member of the patient, the wife, the children, elderly at home, and they'll be giving them preventive prophylactic medications for the whole 6 months. Not only that, those patients will be monitored by the particular DOT center or the TU which is taking care of the patient, and they'll also be given some tests as per the program guidelines. So what TPT basically does is it now includes the whole family as a unit, and once the patient comes, the whole family is included into the tuberculosis program, so that we can hit latent TB hard. Because what the hypothesis is the more that you aggressively address the problem of latent TB, the easier it will be to eliminate tuberculosis from the society.
Okay, so I think ma'am is online. I can just see something in the chat box. Yeah. So Ravi, just to take the discussion ahead before ma'am comes in, if I'm getting it right, are you trying to say that if I have a patient of pulmonary tuberculosis, open case of pulmonary tuberculosis, and there are 10 people residing in the house, then all of them should be investigated whether they have tuberculosis? Will that be the first thing which you do? I'm sitting in my clinic. I have a patient, AFB positive. I ask the families if there are 10 people. It's a joint family. Children, elderly, senior citizens.
Can I come in?
Come, ma'am, please.
Can I come in, Salil, at this time? Right.
Yes.
If we look into the background of TPT, we have to understand two things. One is a household contact is at more risk because there is a history of contact as we always evaluate in all our patients. That's one thing. Second important thing is the all other factors which may be poverty, low immunity or nutritional deprivation, whatever. All these factors remain common for that particular household. And that is why one has to screen all these household contacts. And as Salil was saying, should I screen all 10? Yes. The answer is there are 2-3 different policies which are now prevalent. One is you give a blanket treatment or TB preventive treatment to all after excluding active TB in these contexts. And the second is you exclude active disease, then test for any other evidence of latent tuberculosis and then offer TPT. That is what it is. So the question which you asked that there are 10 contacts, should I? Yes, you should ask symptom complex. You should see whether there are any lymph nodes. You should see whether there are symptoms of persistent cough. And in spite of that, even if everything is negative, and with your clinical experience, you feel that chest X-ray must be done, you can get a chest X-ray done.
Okay. So virtually the answer is that all of them should be screened by taking their history and.
See, these are at more risk. These are the potential candidates who are likely to have tuberculosis later on. And I'm sure in your practice, you must have seen many patients who have more than one case in the family. Like somebody has active disease, somebody has sputum positive or a microbiologically confirmed, or then there is a person who comes up with pleural effusion, and after 2-3 months you see somebody coming up with a lymph node. And this is irrespective of even the socioeconomic status that we have seen, and even you must have seen.
So of course, before we talk about the technical difficulties to get all these people to come and get tested, because I would like to have a real-time scenario about when we say that we need to rule out active TB in these people. Are we able to actually rule out active TB disease by doing the screening of Mantu or an X-ray? So
that's where the challenge lies. Even I believe that the first point what has been mentioned under the contraindication is that it should not be an active case of TB. And to rule out active TB case is a real challenge, sir. Because we know, we come across patients where we won't be able to pick up these small mid-intestinal lymph nodes, necrotic nodes, subcarinal nodes, only on X-ray basis also. Many times they are subclinical, so they don't have symptoms, they don't have cough, they don't have fever, but yes, they have a history of contact at their home. But if you get an X-ray chest done, and the X-ray chest is absolutely normal, you won't even think that there could be a small node sitting at a subcarinal area, which is a necrotic and which is maybe active. Many times we also, pick up such small nodes only with a CT with contrast. But getting a X-ray done for all, or rather suspected lesions, getting a CT scan again and exposing them on scans, and then ruling out something is something really what even I don't understand, sir. How do we go ahead with it? Dr. Padmapriya, madam, since you are already over here, can you put some light, throw some light on it, ma'am? Oh, I think the network is really weak. Dr. Padma, ma'am?
So I think ma'am is unable to log in.
Can you hear me now?
Yeah. Can hear you. Perfect.
Can you hear me?
Yeah, we can hear you.
Okay. So to answer Great. So to answer or rather continue with Dr. Vikas's thought. So the newer guidelines, which was released in July 2021, the guideline clearly says it is not only symptom screen, but you have to do a chest X-ray, right? So I do agree, in chest X-ray, you may miss a subcarinal node. That is always there. But it's just not the symptom, but also the chest X-ray. And if both are normal, then you ask for a contraindication for TPT before you give somebody TPT. Now the question is, how much more? If you do only a symptom screen and then you do a symptom screen under chest X-ray, what are the likelihood of picking up TB? So when you add chest X-ray to symptom screen, your sensitivity goes up to 9.
Okay, I think we have,
is 7% to pick up a TB case. Okay, I agree there is a 3% still chance that you might miss TB. So Dr. Vikas, sensitivity of picking up TB. If it is negative, then you go ahead and you can give them TPT.
Ma'am, just to add on over here, one more thing.
If you do not have access to either an IGRA or a C. Now, these two are very specific for TB. If anything.
Accepted. So, ma'am wants to tell over here
Yes,
is
Dr.
whoever patients are IGRA positive, basically just go for an X-ray chest, check for the mediastinal lymph nodes. If you are seeing any lymph nodes, and if the patient is also having.
Because even your network is not clear. Because...
Okay. Am I audible now? Clear? Yeah, I've just off my video so that I could be more clear.
Now it is better.
Yeah. But Padmapriya ma'am, always, it is not only X-ray chest where we could see only a mediastinal node, but sometimes if there is a small inguinal node or if there is a small mesenteric node sitting somewhere deep inside the abdomen, then how do we pick up those nodes? And it's not necessary that even with 1 centimeter of the lymph node, patient may show some symptoms. It is not necessary. Many times it happens that patients show symptoms later down the line, maybe after 2 months, 3 months. By the way, the patient would be already exposed to the TPT drugs which we have decided over there, which may lead to only mono or just dual drugs giving to the patient, that too on the alternate, as the interruptive treatment over there. So how do we justify doing that, ma'am?
Okay, so point one, a scenario, let us say somebody walks into Dr. Vikas's clinic. He doesn't have any cough, any symptom, nothing, but he comes to your clinic with just a small 1 centimeter inguinal node. I do not think you will directly go ahead and start him on TPT, or even TB treatment for that matter, right? You will not put him on a 4 drugs, diagnose him as active TB, start him on treatment. You will investigate for that lymph node, correct? Or even you put him on anti-inflammatory and see what happens to him after a week. The same thing can be done here, Dr. Vikas. Not necessarily, we are saying that even if you suspect.
The scenario what we are talking is where the patient is asymptomatic, a contact of a TB patient, and where we are thinking of giving him TPT.
No, just let me finish. So the question is, what you're trying to say is, that is fine. That is fine. All I'm saying is, if you have even a little suspicion that that particular node may be TB, do not give him TPT. You can investigate him further. It is also there in the algorithm. Wherever if you think this node or even a small node that you visibly see, you can go ahead and not give him TPT. At the same time, you have done a chest X-ray and you do not find anything. You still suspect the patient may have an abdominal node. Do not give him TPT. We are not forcing anyone to be giving TPT. All we are saying is, ruling now chest X-ray initially only sim करो. Chest X-ray में कुछ नहीं है, no other because if it is abdominal node, he will definitely have some in the positive. You rightly said, not today, 3 months down the line. If you want to wait, you can wait, but no point giving somebody TPT after the index case is completely.
Can I take the
right? Third point.
Amita, I'll just get you into the discussion, but just making a small comment, then we'll get Amita into the discussion. So there are, first of all, every time patient's history, we really don't know how reliable it would be in terms of asking about cough and weakness or weight. They are vague symptoms. Everyone know patients just come with tiredness and weakness, and they mimic it as actually fatigue or loss of weight. And there are many things in the OPD. It would be difficult perhaps to screen them. X-rays again would miss smaller lesions, smaller cavities, which would be actually seen on a CT scan. We very well know that. As Vikas pointed, even the lymph nodes may be a little difficult actually to check whether they are significant in size or not in terms of an X-ray chest. But having said that, Amita, you can put up your views and then we'll bring back Ravi and ma'am again in the discussion. So Amita, please put up your points. You unmute yourself. Unmute yourself.
Yes, yeah. Sorry. Yeah. So actually, the thing is, just taking it forward from what Vikas said, Vikas was quite correct. The patient could be having an inguinal lymph node. Now, this patient has a family member who's TB positive, and he is being investigated based on symptoms, chest X-ray. Are we expecting anybody to actually look for an inguinal lymph node in this patient on examination? And the patient himself may not be aware that he's having an inguinal lymph node. So I basically feel that we are jumping into wanting to treat people who may not end up having TB at all. But in the bargain, those people who are actually harboring TB medicine, actual TB, we are exposing them big time to get INH monoresistance when we already have 16% INH monoresistance. So what are we trying to achieve? If we were actually ending TB in a country, then giving preventive treatment made any kind of sense. Here, active case finding is so important. Diagnosing drug resistance is so important in an active patient. So instead of concentrating completely over there, we are actually creating more drug resistance by actually talking about and implementing preventive TB treatment. I feel it's a very premature and a very unnecessary decision, and I hope people are hearing me because I don't want to mince my words here.
So Amita, probably ma'am will also put up her thoughts, and even Dr. Radha Munje ma'am or Ravi, one of you. But when these whatever I know about, when this protocol, this strategy came into place, they have categorically mentioned there that it has not shown to increase or induce drug resistance when we talk of INH as a monotherapy. That's the statement which has been made there. So I would want, in fact, ma'am or Radha Munje ma'am or Ravi, whoever, to tell us how does that statement come up. Like when we always say that don't add one drug, you should never give this drug, it may induce more resistance, it's a more risk. In fact, for MDR, we have always stopped adding a single drug, thinking and knowing that it can induce resistance. But when we are talking of this strategy, it clearly mentions that the chance of drug resistance is not seen as per the studies which have been done. So I would, Amita, you can put up there.
So 1 second. So the thing is that, RNDC, NTEP has its own slides in which one of the slides says that from the studies, we have seen that the drug resistance is not increased, but we are talking about a limited number of people over here. And the thing is that we really don't even know what kind of efforts were made to really know if they were drug resistant or not. So it would be really nice if a separate paper was brought out to exactly let us know what all investigations were done to know whether this was drug resistant or not. Because
right, because many places there are no diagnostic tools available for, even if we want to go for further more investigation deep over there, maybe only after X-ray chest, not only X-ray, but if we require some ultrasound or if we require to do a scans over there. So many remote areas, they don't even have the facilities over there. And guidelines have mentioned that even the if you don't have the provision of screening over there, the TPT should not be holded. Now, how are we justified, for particular statement over there?
So Ravi, Ravi, Radha Munje ma'am,
I think we will ask Padmapriya ma'am because she's going to take off, the flight is going to take off.
So Padmapriya ma'am, of course, we would want her to tell us, because this particular question of resistance, I can see a lot of questions on the chat box saying that won't they cause resistance. So can you please tell us about it? How aren't we increasing or putting them at risk?
Padma ma'am?
I think we lost our network again. possible.
Yeah. Can you hear me, Dr. Salil?
Yeah, we can hear you.
Yeah. Fine. I've already put my thoughts in the chat box to the question about resistance. And the other person was asking about do we have studies? We have studies even from NIRT, a separate study where we did follow up patients who were hooked on TB. This was even HIV infected, children, everybody. And in that, we did have patients who had a breakthrough TB disease, and those specimens were tested for DST for isoniazid. We did not find resistance. So what I'm trying to tell is, as of now, whatever evidence that we have has not shown an increase in the resistance after taking a complete TPT. ऐसे नहीं कि एक महीने उन्होंने खा लिया उसके बाद उसको छोड़ दिया, and then he comes back after some time and then you develop resistance. If somebody is on TPT, if it is a 6 months of TPT, completed diligently, chances of him developing resistance is not there. At least as of today, we don't have enough evidence. But I agree, all the patients you are putting them, we can do a prospective cohort, follow these patients. And we have evidence from India. I think somebody's comment was we don't have evidence from India, but we do have. I can share those publications with Dr. Vikas. I can share them with you. It's available on public domain. We do not have evidence shown by giving 6 months of
Ma'am, this they were followed up for how much duration after the TPT?
Numbers of people.
24 months. 24 months. The numbers are 1,500. It is available online.
Here, ma'am, we are asking about the breakthrough. What was the number of people who got breakthrough infection who were INH sensitive? What was that number?
Yeah. Okay, so patients who took the TB therapy, I mean the preventive therapy, so guys who were hardly 13 patients, TB and none of them had, they were all HIV positive, none of them had resistance. That's what I'm saying. So irregular 6 months of isoniazid is too long a period for someone to take, someone who is not insured. What we find is even if you're disease, people do not tend to complete a longer therapy.
I'm asking a very specific question.
Let madam.
And I.
Can the organizers mute the audience, please? Because there's a lot of.
I think Radha, ma'am.
Yes, can you hear me?
Yeah, we can hear you, ma'am.
Okay.
There's a lot of background noise.
Can you repeat? There is a lot of. Can you repeat?
So Amita was asking one question to you. Amita, can you just pick up your question?
No, not to Radha. I was asking to Dr. Padmapriya.
Okay.
I don't know. Basically, I am asking a specific question that out of the trial of 1,500 people who were given INH polio prophylaxis, what was the number of people who got breakthrough TB? The number of people who got the TB infection. Because if we want to talk about there was no drug resistance, the number of people getting breakthrough TB, that number is very important. So what was the number of people who got the breakthrough infection out of 1,500 people in India who were given TPT?
Amita, what I would suggest is the number of patients who, people living with HIV who got the disease after completing or after incomplete preventive therapy was in single digit. It was somewhere between 10 or 12. I don't remember the exact numbers, but it is already available in publication, Dr. Ravi. I don't think there is anything for you to smile or laugh at. It is very much available in public domain. I can share you the published literature where we did not find resistance. That's what I'm trying to say. If you rule notice, I'm talking about patients who are on ART therapy.
So is 12 a significant
6 months of isoniazid?
Salil, what do you feel is 12 a big number for us to make statements?
No.
That it is not.
No. Amita, what ma'am is saying is from the data which they have got, though it's a limited number, they have found that the number of patients of breakthrough are less, and ma'am is just mentioning that for 2 years they followed up these patients and they did not find any patient developing resistance as far as the sensitivity and culture tests which done. And based on that, they have probably said that this would be...
Salil, you misunderstood. Patients were followed up for 2 years to see whether they got TB or not. That is a separate thing. Okay, because you say TPT is working. If people don't get TB first. So basically the success rate was 60%. Okay. It was not a huge number. The success rate was 60% in this trial. I'm aware of it. Okay,
Yes.
which according to me is not a huge
Yes.
number. And if 10 or 12 people got breakthrough infection, and if 10 or 12 people were still INH resistant or were still INH sensitive, this is highly small number. This is not any kind of a number for us to
No,
assume.
no, I agree, Dr. Amita, I agree. This is a small number. We have no claims. It's not such a large number. All I'm trying to tell you is it is a small number for a population that was followed up meticulously for 24 months post IPT in a vulnerable group in HIV. This only answers the question that even in our country, we do have evidence on this, especially when they've been repeatedly exposed. It's not unlike other countries where you once give, they don't have exposure. Here, every day in and out, everybody is exposed to TB here. They still did not get it. It's a small number. All I'm saying is we do have evidence. And currently, what the program is telling is you give them the drugs and follow them. We are not saying you leave them alone. Follow
Ma'am,
them. Follow them
yeah,
for 2
ma'am,
years.
sorry to interrupt. What happens, Ravi and ma'am, Radha Munje ma'am, also I want them in the discussion is, ma'am, unfortunately, we are seeing resistance increasing and it becomes very difficult for us to treat even 10 patients or 100 patients or 200 patients. It becomes difficult to convince and for them to actually sustain. So when we are saying, as Dr. Gyan Shankar Mishra has put up from Nagpur, I think ma'am must be knowing, he's mentioned that monotherapy with INH will lead to INH resistance mutation when the total number of bacilli will be more than 10 raised to 6. And in latent TB, the number of bacilli are less and not active. So if active TB is ruled out, theoretically, monotherapy will not lead to INH resistance. Now, theoretically, in a small sample of patients, it looks to be fine and safe and effective. But when we come to practice, when we are seeing mass a number of patients, where one patient, even if he's resistant, he may actually infect 20 to 30 other patients, and that is going to further multiply. If we are getting this into a protocol for all over the country, we may actually miss the bus and we may land up. The apprehension from the pulmonologist is that it's the apprehension that we should not be actually causing more trouble when we already have trouble. So that's where the apprehension arises from. So Radha Munje ma'am, you can please tell me if I am right, and since you are also having, you are always been vocal about things. So please tell us if I'm right in speaking these things. Not audible.
Radha, please unmute.
Hi, can you hear me?
Yeah, we can hear you.
Yes.
Yes.
See, I have understood your question well, and I understand and appreciate the concerns raised by Amita, Vikas, and Salil. And being a clinician, I would partly agree to that. I agree that there have been small number of people who had breakthrough infection, and in them resistance was not demonstrated. However, that number is not sufficient enough to prove that people would not develop INH monoresistance. On one hand, we have explanation given by Dr. Gyan, and we should look into that also with a clear mind. One thing. Secondly, we have to look at what Padma is saying, that it's a model which has been studied in HIV positives who are most vulnerable population for breakdown of tuberculosis throughout their lifetime. Right? It's not a single point contact like it happens in patients of a sputum positive case. Because once that case is cured, there are no chances of the other household contacts being getting infected often. And still they have replicated that model and come out with us. So I think that we should equally look at the positive data, that how many active TB cases were prevented, because that is the purpose of introducing TPT. And when we talk about TB control, the speed with which we are going, we are not going to achieve that any time in our lifetime. ऐसा मुझे तो नहीं दिख रहा है. So to hasten that speed, we have to put in efforts like TPT or vaccine. As of now, we do not have a vaccine which would bring in this change and a rapid decline in number of cases. Perhaps after a year or two, when we talk, we might have something substantial. So that is why I'm just telling a background of why TPT is being introduced. I'm not saying whatever issues are raised are not correct. I'm just saying what model has been replicated and why it is accepted. As and when we get more and more cases who come out with breakdown disease, one, or if we come across a scenario where most of the household contacts or many have active disease, then we would be apprehensive about TPT. Second. Third, importantly, TPT is not mandatory. It's an option available with the clinician, and it's an option available with the household contacts whom you are screening and offering. While saying all this, I am neither supporting anybody nor opposing anybody. I just wanted to make clear the background and the purpose of TPT. Whether and secondly, about single drug, as a clinician, I too have apprehensions. However, if you would look at WHO guidelines, we have recommendations of INH rifampicin and INH rifampicin to be given. And that too, once you have ruled out drug resistance in the index case. It's very important that you have ruled out INH as well as rifampicin resistance in the index case before talking about TPT to their household contacts.
So two things I can gather
know Amita is also going to ask me.
No.
I know, and Amita is also going to talk about. As of now, we are talking about only INH monoresistance, and she's going to ask me about why single drug for MDR to be contact. But I'm sure that question will come in the time, and whenever we have discussion, we'll discuss about it.
So I will get Vikas and Ravi from their side also, but two submissions.
And the concern raised by Amita or Vikas, you are common concerns with me also. I'm not refuting that concern of what do you say, augmenting the resistance or developing INH resistance, which may happen if the patient is having active disease. But then the onus of active disease lies on the treating doctor. To rule out an active disease lies on the doctor who is offering TPT.
Radha, can I say something?
Yes.
Yeah.
Radha, I don't know why a person like you, who's normally a straight talker, being so diplomatic today. Really...
No. I'm not being diplomatic. See, I told you. I share your concern.
Radha, let me complete. Okay. You are saying that the onus of ruling out active TB lies on the clinician. We know what happens at district level. We know what happens at smaller centers. We don't have access sometimes even to test X-rays. They don't have access to ultrasound. I mean, what are we subjecting? I am saying that.
Nene, see, but we have not made it mandatory now. It's an option given. Patient also in the context can also refuse.
So,
the doctor can refuse saying, I don't recommend this.
No, so three submissions. Amita, I can get three submissions here from both the ma'ams. One is that there is
and whatever I said is I was just stating the background. I never said I'm supporting this.
No,
I never said that you accept it as a policy and follow it.
No, that's fine. Your view is taken, no doubt. So one is that there is a definite apprehension and unsurety about whether this may induce a resistance or not. We are not sure of that. One, that is definite, at least from what I am gathering from the discussion. That's why we are not being sure. I mean, that's the basic reason that we are not vocal and we are not able to emphasize that you should start it, because we are not yet sure. Second is the sample size, as ma'am was also saying, was smaller, which also we know that it may be a bigger group or maybe a bigger trial size would be something which may be boosting our confidence in using it or starting it. So these few submissions I have, because from your point, you please put up your stuff.
My only concern is that only being a clinician over here is to how do we rule out active TB in any given point of time? It's next to impossible. Like we cannot scan the patient through our eyes, or we can't just judge that that judgment like this patient may be negative or may not be having active tuberculosis. Because many times when the patient comes in front of me in OPD, it's not that the patient is coming with some symptoms over here. He is just an attendant with a primary case. Now we are treating primary case over here, but we suddenly cannot just switch over to the attendant and start asking him probably, do you have any symptoms? Do you have any fever? Do you have any cough? If yes, if yes, we may just get your XHS done, where we may just slip those minute nodes which are not even sitting in mediastinum, maybe somewhere in the abdomen, somewhere in the axilla, somewhere in the inguinal region, or wherever it may be, and which may be asymptomatic. Absolutely, many times it becomes asymptomatic.
So Ravi, yeah.
Point of time.
Yes.
Yes.
Ravi, Vikas is constantly emphasizing that. Okay, one more point. Yeah.
The concern is because when we roll out the guidelines, many times it has been just taken away by the health officers who are sitting in the remote area, in the villages, and in the periphery centers. Absolutely. They just know one thing, probably, that sometimes there are some limitations of getting further screening done. Yeah. Sometimes it is lack of maybe skills over there to really rule out the active TB and just go ahead with the TPT, since it's been mentioned over there, the guidelines, to follow the protocol over there. So I'm just concerned with this thing. Yes, TPT is needed, but not now. Maybe it would have been a bit at the later point, but not at least in a place where there is high incidence of TB, or maybe in some villages where there are low incidence of TB. It's still, I think, still okay. But when there is high incidence of TB, like the place like Mumbai, if you talk about Mumbai, sir, all my patients I expect only pre-XDR. Forget about TB. At the moment, I just see any patient, and even if he's asymptomatic, and if I just happen to screen him, and I just want to find a small node sometime accidentally, if I just biopsy that node, it turns out to be pre-XDR, surprisingly. And then the mother tells us that कोई problem ही नहीं है, sir. आपने इसको कराया, इसके लिए इसको MDR निकला.
So Vikas, your point is going to be discussed by Ravi, but let me just tell you the basic principle, for preventive strategies are actually to bring the area from high prevalence to low prevalence. That is the basic strategy where we want, okay, it is a high prevalence area and it is more resistant, so we need to get it to a low prevalence. So whenever the strategy will come in, it will of course come to Mumbai, though it will be always remaining into the high prevalence. That is going to be the bottom line. Right now, your question is very valid. I think Ravi should be able to answer as to how do we really go about in ruling out active TB disease, and what's your best way to to simplify it. Just 2-3 points you can tell.
I would like to learn this thing.
Yeah. No. It's not a question of learning, sir. Basically, it's making the person sitting on the chair a bit smarter. What the program has actually done is it has put a lot of responsibility on the treating physician. What Vikas is saying is very correct. For a person who is ignorant and following the TPT protocol blindly, he might be ending up harming us more. But what is required is we have to be more efficient. We have to be more careful in deciding what we are dealing with. Even if we are starting TPT, definitely active disease has to be looked into very carefully. Now, your question was, how do we go about diagnosing active TB? Well, the symptoms, fever, cough, infiltration on the X-ray, and definitely one thing that TPT does is it makes the household contact of the TB patient a bit more aware. The doctor at least starts asking them, do you have this? Do you have this? And inadvertently, over a period of time, we might be helping patients by increasing this awareness. Let us look at it from that point of view instead of only from a treatment point of view.
So Vikas, you got your answer. So it is clinical acumen coupled with few investigations. But Ravi, you will also agree with me. The difficult part comes in terms of extrapulmonary TB. And when we diagnose TB, by that time he's already infected his family members who are staying in the house. And one of them could be a diabetic who is uncontrolled. But at that point of time, he may not be showing the activity, though he may be harboring the active TB. That's what we are discussing. And in this patient, we are actually giving him isoniazid. He's having active lesions. And
sir, what I would like to say, sir, it has always been difficult to bail the cat. But at least now the government is making an effort to try to bail the cat. It is going to be difficult. It's still another few years away by the time we actually achieve the true purpose of TPT. I believe these 2 years will be where we need to have more careful approach. The voluntary nature of TPT is something that actually what I feel is a question mark. I feel it should be mandatory. But again, what Vikas says, yes, ruling out active is difficult. that is one thing that we have to be very careful about, where Mantuk TST and IGRA testing might help us. And I believe TST and IGRA testing are now present at almost every level of the country.
Amita, you want to make a point here?
Yeah. So basically, I want to just say this only, that whenever government rolls out a policy, I think everybody who's associated with the program knows that you have to make sure that you are enrolling more and more people into that policy. There are so many treating doctors who tell us we don't believe in the shorter bedaquiline regime, but we give it because we have to show numbers. So the minute TPT is made mandatory, the smaller people in smaller towns will be forced into giving it when they don't have amenities to rule out active TB. I mean, how often we also try to rule out active TB? We may do a CT chest, but if at all a PET CT is done, you may find out that there is a normal size node which is showing activity, and you do biopsy and it turns out to be TB, and even gene expert will show MTB detected. So what I want to basically say is that it is not easy to rule out active TB by just doing a chest X-ray. A subcarinal node will never be seen on a chest X-ray. You know, prevascular nodes, any aorticopulmonary lymph nodes will not be seen. And these patients will not even manifest any symptoms. And we know that in extrapulmonary TB, MAN2 is usually negative because there's compartmentalization of lymphocytes into that particular area. So for extrapulmonary TB, if you want to go by MAN2 or IGRA, then of course it's not really going to work out. So what are we achieving? These people may not have even given infection to anybody. Extrapulmonary TB people are not infectious, but you're giving them INH and you're making sure you're creating INH resistance in them. What have we achieved?
Before going ahead, I would like to thank Dr. Padmapriya ma'am, who had joined along with us outside the flight. She had already boarded the flight and the gates were supposed to get closed. So I think now the gates have been closed, so we are not going to join her very soon now. We're going to miss her.
So yeah. Amita, just, I'll read out two sentences from this particular strategy or this particular study. One is that the studies, whichever we have, 75% of the people who developed TB disease after contact with a patient with active TB are estimated to do so within 1 year of diagnosis of the index patient, and 97% within 2 years. So a contact of an open case that. And what next it says that the risk of developing TB disease by giving TPT decreases by approximately 60%, and the reduction can be up to 90% in people with HIV. So they are banking on these two statements from the studies which have been, that we are able to reduce. Yeah, I know I'm giving this statement to everyone. Whoever wishes to make a comment, we can make, no harm. So now these differences, and what you and me or Vikas have our difficulties is about 1 case, 2 case, tens of thousands of hundreds of cases. And they are talking in terms of masses, which the percentage has come down. So the debate is actually related to that, because from a point of view of a statistician, it definitely looks to be very good and very theoretical. But does it really percolate?
Sir, as a clinician, we all know one thing, that is something called as fall and rise phenomena.
Yes.
Similarly, over here, what if probably the cases numbers are coming down for now, but later on they will multiply tenfold and will give an augmented resistance over there.
So precisely.
We need to learn something from our past. The category 1, we used to give alternative regimen, where continuation phase we used to give only HNR. Those days we were not having tool to diagnose INH sensitivity because of LPA was not present over there those days, and we unknowingly gave only rifampicin, where we landed up resistance augmentation over there. Similarly, the concern lies over here with all the physicians, the clinicians especially, that though these numbers are seems to be very good for now, the concerns are not for at present, but for later on, we should not regret to the decision, nothing else, sir.
No, I agree with Vikas completely. And one more contribution, Salil, to what you told. So basically, the thing is that TPT is actually for countries where active TB cases are very few. So chances of getting disease again and again is not there. For example, I got infection, I got MAN2 positive, I took TPT. 2 years later, I got infection again. My MAN2 is positive again. Will I again take TPT? Third time again, my Mantu is positive again, I'll take TPT because we don't know TPT effect lasting for how long. People who've had TB also get TB again because of reinfection. So the thing is that the funda of giving TPT is only for those places which have low prevalence of TB so that chances of reinfection come down. In our country, when we have so much of active TB, we are completely creating a huge crime. And I use the word crime because I like to be honest. I don't like to be diplomatic. I don't like to be political. Over here, it is something which is too premature and we are harming poor people who have no concept. They come to us with all the hopes and they are the people who are getting jhap. Nothing will happen to us. For example, if I have TB contact in my family, if I want to take INH, I'll do a full body PET CT. I'll make sure I don't have any TB. Then I'll think of taking INH prophylaxis. Are we going to do that for anybody? So we need to be very honest about how we're going to treat ourselves or our relatives and other people and then talk about whether policies are good or not. Because we can't harm people. It's not correct.
No, and many places, many areas, so-called X-ray tests are also been done as a miniature form, sir. Now they have done like it's a miniature X-ray. On that miniature X-ray, how do we rule out that mediastinal node? Or how
So absolutely. So that these are absolutely problems which all of us are facing.
Problems.
The diagnosis in terms of extrapulmonary, in terms of activity of the disease, and we are pushing them with INH, and even for that matter, what I can read is levofloxacin as a drug for contacts of drug-resistant tuberculosis. Radha Munje ma'am is there with us. So ma'am, can you tell us a few things for the next some time about how we are going to manage this? I mean, how have they come into place without really clearing these apprehensions, which are worrisome? No, you're unmute, please. Unmute.
That was what I was saying when I was talking about INH TPT. I just told about the background that why a TPT is needed, how it's being introduced, what are the prerequisites, and what are the difficulties in the prerequisite. Other concern which Amita raised was apt, and it is a concern with me also. And at the same time, I said that I know that once this DSTB part is over, we are going to talk about MDR, and then again with a single drug. And that too for contacts of MDR, because even we have seen that even in the same family, if there are two cases of MDR, the spectrum may be entirely different. It need not be same. So I have equal concerns, and single drug treatment for contacts of MDR TB, I don't think anybody would think of it and approve, and especially for a drug like fluoroquinolone, where drug resistance to fluoroquinolone is of a very higher tune. I think it's somewhere around 33% or some 35%, something like that, as has been revealed in NDRS. And we know that in the community it's as high as this. And even if you rule out any quinolone resistance by second line LPA, in that case of MDR, like it is a prerequisite that there should not be a quinolone resistance. Still, other drug resistance cannot be ruled out. It takes very long time, and till I myself personally would never agree with that. But we are here to even discuss about the policies, and I did not get time to read about the background or the rationale behind the fluoroquinolone single drug therapy. If Ravi or Vikas or even Amita has gone through that, they can put up whether it really exists or what has been the basis to make this policy.
So, Dr. Meena,
I had read about INH, and I knew the background, and that is why I could state I am not refuting any concerns raised or any opposition for that matter.
And with these apprehensions and worries and difficulty in getting this into place, plus the technical difficulties in the interiors of our country where facilities are not available, pulmonologists are not available, great clinical acumen and treatment diagnosis is not available to roll out a program for a country where we are not sure. Even today, there is a big dilemma of ye TB hai ki nahi hai. And then the question is it MDR or not MDR? Then there is a question which regimen to use. And in this given background, to roll a program where we are not sure. I mean, from everyone's views, we are clear that we are not very sure. It may be beneficial. It may be.
See, Salil, what you are saying is very true. And on another platform, I heard Amita raise a big concern about the prescription patterns also. And do we really have a remedy for that? Can we rectify that? But that's another huge debatable topic. We not only have a geographical variation, but we have lots of variation in prescription patterns. People, we look at the world as we are, but the world is not so. It does not consist of n number of you, me, Amita, Vikas, and others who look at the guidelines, try to follow and make the best for their patient. Okay.
Yes, ma'am. Ravi, if I ask you a question, would you give INH prophylaxis to all your residents who are working in the respiratory ward?
No.
Well, sir, I would, sir. I mean, no harm in that. As per guideline. And I'll be making it voluntarily and ruling out active TB in them.
What test will you do for active TB ruling out?
Ma'am, symptomatology, X-ray, and sputum.
Okay, so they could not be having subcarinal lymph nodes?
They could be, ma'am. I am for TPT because I think a change is needed in current tuberculosis control practice. And if that is the way forward, we have to somewhere go forward. Means current elimination and tuberculosis control strategies are not working towards elimination. That is the point. I support TPT in principle, ma'am. All technical problems are there, but I think TPT is the way forward.
I personally feel that every change need not be for good. And TB is not getting eliminated because we are blindly following many things which are being followed for other countries. We are not understanding limitations that we face. We are not making sure that there is, we have proper support to implement things. The minute we start strengthening the actual rules, then we will actually achieve huge things. Because program B is very good, but please concentrate towards it.
Sir, Ravi sir, just one small question. Suppose if any of a resident, tells there are no symptoms, no fever, no weight loss, nothing, but खाली एक डल एकिंग लोअर बैक पेन है, सिर्फ डल एकिंग. वो तो मतलब पिछले 10 दिन से मैं काम बहुत कर रहा हूँ, बहुत ज्यादा आप लोग ने मेरे को सर काम करवाया है, वार्ड्स में राउंड दिलाया है, तो मे बी दैट कुड बी रीजन, डोंट नो. So would you go for MRI scan for that particular resident to rule out even if there is a small foci sitting over there as a pot spine, which you don't know, the symptoms have started now as a lower back pain for 15 days, which may go long for 1 month, 1.5 months, till time he don't get his MRI done and diagnose himself as pot spine.
No, I agree. I won't be going for an MRI for him. I fully agree with what you're saying. But the point is that in this given situation, chalo, I'll make a very bad comparison. I know it is a bad comparison and ma'am is going to cook me like anything. Don't you know about people who have been taking HCQS prophylaxis for COVID-19 throughout the 2.5 years? Tell me. I know about residents who are taking isoniazid. Means I'm not justifying anything. I'm telling you the reality of facts which is there. I know of people who are doing this. I am not at all justifying anything. Believe me, I'm as a core clinician that you are. But looking at the program and looking at the change that it has brought, we need to be more smarter in choosing these patients. I fully agree with you.
Sorry, but you cannot compare oranges to apples. Okay,
I know, ma'am. I know.
It was like really too pathetic to even be spoken about. What is about HCQ resistance and what are we talking about INH resistance for a killer disease? I mean, why are we getting... Let's not. I feel we have to be honest to our branch and specialty.
You admitted that you're going to cook him.
I told beforehand only because see, I know the force for TPT. For me to sit over here and support it is difficult for me also, ma'am. But my point is, maybe over a period of time, some change has to come in the program. I would have been really happy if Priyadarshini ma'am, Radha ma'am would have been there in full swing to support me. But we need more evidence. There is no doubt about it. And maybe in a more better and effective way. Maybe in not all patients, but at least in families where we know TPT might work. At least in them, we can start giving it to them.
So Ravi, ma'am, Radha Munje ma'am, in fact, twice has told very clearly that she is herself apprehensive whether this is going to be the correct step or not. So that's a submission which we need to, accept that there is a apprehension. Once there is an apprehension about ruling out active tuberculosis and what repercussions it will have.
Salil, See, what I said is apprehension about the data and developing lineage resistance.
Yes,
But at the
exactly.
same time,
Exactly.
when
The
we are
same thing. I'm
concerned,
talking about the same apprehension. Yes.
नहीं सलील देखो एक किसी भी कॉइन के ना टू साइड्स रहते हैं एंड अमिता आई एम नॉट बीइंग डिप्लोमेटिक आई एम बीइंग रैशनल right what I want to say is for example you have treated 100 cases of household contacts right and you have prevented 80 people out of those 100 let us assume that only 30 people were about to have a breakdown in the coming 3 to 6 months you have prevented TB in
Network is not. I think her network is not right. She's at the airport. No, that's the problem.
Sir, factually speaking, for arguments in favor of TPT, if all clinicians are sitting over here, it is very, very difficult, sir. Even while starting to talk for TPT, I do understand that there are huge issues with it. So what I would like to narrow it down as a person in favor of TPT, to not give it blindly to each and everybody, but at least there are families which you can identify to be intelligent enough in which you can give it, or maybe in which total workup can be done.
So very sensible point made over here. The first concern was that how to rule out active TB. Second concern is basically still if you are forced to give TPT in your area by any of your authority, please as a clinician make a maximum possible utilization of your skills, whatever way you want to go ahead with. Go with a very thorough history for your patient. The person who is sitting in front of you is not a patient whom you're going to treat. He is just an attendant of a positive patient, right? Contact of a positive patient. So you need to have an utmost care over there that, you need to be very smart enough to dig the entire history, to screen him till the end, and be rest assured that yes, after screening him thoroughly, now I feel that 99% he is not an active TB, which is next to impossible. There is no test which can rule out active or latent infection. There is no test. IGRA can just tell you whether exposure or not exposed, and X-ray and radiological things will just give you an supportive diagnostics. They are not for confirmatory diagnostics, but still we need to really, because this is a challenge I faced at my site. When my site got orders of rolling out TPT over there for all the patients, screening each and every patient became a task for us. Counseling them, why are we conducting the test? If on X-ray we had some small patches also, we need to further test, investigate him, which led to further questions to be answered. So a lot of work was being done behind one person. So I can just imagine if it is like, that kind of efforts behind one person, one patient family, then rolling out should not be just like Liya or Diya. Waisa nahi hona chahiye.
So two aspects to this before we wind up with the next 10 minutes or 15 minutes. One is the logic and the science, and second is the technical difficulties. Okay, these are two different aspects. If logic and science are worthwhile and perfect, then technical difficulties can be planned, managed. Those are completely a different set of problems which come up. But at this juncture, yes, ruling out active TCs, I think no one will have an answer to say this is the patient and this is. I mean, I agree. I know every one of us, we get references from ophthalmologists, we get references from gynecologists who say that IGRA is positive, MANTU is positive, start anti-TB drugs. And even at that point, we try to hold it back because we are not saying that IGRA and MANTU test means we should start on treatment or active disease. It's always a dilemma which keeps on jumping. So it's going to be a very difficult one. So the first point which says that active disease, then that is the best way to go ahead with the TPT is itself on a wobbly ground. Second is about the risk in drug-resistant tuberculosis. So as Vikas, you must have been seeing so many patients of drug resistance and you call them and then you, maybe because they are not symptomatic, X-ray is normal, you start on levofloxacin. We never know after 3 years, 2 years, what is going to be damage happening. And then that patient is going to cross-infect and so many other people. So that's the fear and the worry, which is a real fear which we have, real anxiety which we have, which is different from the percentages which seem to be good and fancy to see and to read, which is, of course, in the masses, it may be good, but then really it is going to help maybe after 4 years and 5 years. So are we really a little hasty in rolling out this program? Are we being rushed up with the goal that we want to control TB early? Are those things which are driving us, trying to say that this is a good way ahead? I think we all need to really think about technicalities. I think Ravi and Dr. Radha, Amita, every one of us know that to convince a patient that he has TB itself is a task. There will be 20,000 questions coming in, ke mujhe kaise ho sakta hai? How can I? And then telling 6 relatives to come, to explain, to counsel, and imagine one of them develops INH-induced hepatitis without having any TB, no nothing at all, and he lands up with vomiting, gastritis, and unfortunately, it is going to be the prescribing physician who is going to be considered to be at fault, because we can't keep on taking consents every time that this is a prophylaxis and we are taking, it's counseling, it's a verbal communication. So there is also a fear about the side effects, the interactions with different antibiotics, anticonvulsants. We are going to talk about that as well. So Ravi and Dr. Ma'am, if she is on the panel, can we have the interactions and the risks related to this INH or even the INH rifampicin prophylaxis for that matter? So Ravi, any thoughts from you before any one of them comes in?
Sir, definitely there will be interactions. Doses have to be modified and additional diseases have to be monitored in those contexts. We have, like Vikas told very clearly, the burden on the treating person is increasing immensely, because automatically we are having to monitor 6 patients more, and giving INH and rifampicin to these patients is not a simple task. We have to be very careful with medications, particularly anti-epileptic medications or diabetes medications which are going on. And with proper monitoring only, a proper TPT is justified. If we are just giving it blindly, then definitely it is not worth it.
And apart from that, Dr. Ravi, we should also add that whenever you offer TPT, it's after counseling and after due consent. If they're not willing to take, you are not going to force anybody to take a particular drug, right?
Yes, definitely, it is absolutely voluntary.
The consent, which is a written consent form signed, and then only TPT to be given.
Yes, why not?
Can I just bring out a very different angle to everybody, huh? It's a very honest confession. I have been really treating a lot of TB because it being my passion. I can't even think of 1% of patients who in the same family has got TB. Despite looking after them without masks, nobody ever wore masks before COVID. So I'm actually saying that if I have to think and remember that how many in the same family got TB within 2 years, I can't even think of 10. And I promise I have treated more than thousands and thousands of TB. So what I want to really ask is that is it really true that in India, we are going to get so much of benefit from TBT? From abroad, it makes a difference because they don't get exposure anywhere else. The immunity is poor. We have such good immunity. So I really don't understand. I would like to ask Dr. Vikas or Dr. Salil or Dr. Ravi, how many of their patients' families got TB from them?
In my case, we are treating families, to be very frank. There are mothers, daughters, and fathers and daughters, sisters, 3 sisters coming positive within the period of 4 years, 5 years.
Yes, so that is becoming positive here, not at the same time, right? We've also had patients who have one person has sensitive TB and the brother has resistant TB in the same family. The one exposure could be in the office, other could be at home.
There are cases who are mixed heterogeneous.
These permutations and combinations of TB are very difficult, ma'am. That is one thing which nobody is saying yes or no to. But the only thing is, it is an attempt to prevent. It might not be very justified. Actually, I agree with you.
Accepted. But the only thing is, are we too early to roll out TPT now?
Exactly.
And especially to rush in a high incidence burden area. My only 2 concerns. That's it.
Even I agree with that. That concern is very genuine, and we are banking, at least whatever I have seen, we are banking on a study published in July 2020 from our country, which talks about 1051 patients, 1051, which is definitely not a number by which we should perhaps think about rolling out a program. That's my personal thought and belief. So I think we are still not. I think we have got Ravi on our side. I feel slowly. Ravi is slowly coming on our side because we
Salil, I so agree with you. So I just feel that it's not even correct on the part of the program to put in their slides that our study has shown. Then put up the real numbers, no? Why don't put up that study of 1050 people and 10 people got TB breakthrough and these 10 did not have resistant TB, and in how many months did they get it? So all these things give us complete information. Otherwise, don't make such statements. It's incorrect. This is not science.
no, these whatever statements or what we study, they, of course, ma'am said she will share it with you, the details about the exact, the
She said
inclusion.
10 or 12, which is not the best number.
That she will definitely tell you, because with it coming into the national protocol, it's going to be
We will
having
somewhere have to rethink over this, and we will have to take this point and this to be discussed on the higher authorities also. That's my concern over here. Genuine
So
concern.
as of now, what I can gather from everyone's talk is, one is that it's been a little rushed up to really think about rolling it out as a national level program. One, sample size seems to be not adequate enough to talk about giving INH or a prophylaxis with INH rifampicin and with a quinolone. The apprehension is very clear from the questions on the chat box as well as the eminent panelists who have been a part of this program today. Difficulty in diagnosing active TB has been endless, right from the time when I was not a doctor till now. After so many years of practice, every chest physician, every clinician has battled with this dilemma: is it active, is it not active, is it drug resistant, is it not drug resistant? And that problem is a very most crucial segment of starting TPT. That's why we are harping on that again and again, because if we give it and the patient has active TB, he may land up with a drug resistance on an extra pulmonary side, which could be lethal for him. And we may actually push him from the brink and he may land up in a crisis. So these worries are something which are really genuine. Of course, Radha ma'am has told us very clearly that there could be difficulties, there are apprehensions, and it's not very clear about activities of the disease as well as this breakout tuberculosis. So I think each one of you can give us a take-home message so that maybe there is more food for thought in all of us, and then we can wind up for the day. If anyone has got a take-home message or a point to be done, yes.
One question to all of you all. How many of us have actually, we all are coming in touch with TB all the time. How many of us have actually done a Mantu and considered taking INH chemoprophylaxis?
No.
We know most about TB, we are not doing. Then isn't this a joke? Why are we even discussing this?
No, we are discussing because it's coming into the national program.
No. What I'm trying to say is, no. Salil, it's very nice that we are discussing. What I'm trying to say is that there is just no discussion. It's over. Despite being people who study TB for 3 years in post-graduation, we are not even doing a Bantu or IGRA for ourselves. And we want to basically make sure immunity is good.
No, so before I make a comment, yeah, Vikas, yes.
There is no test which can rule out active TB. There is no clinician who can really tell 100% that this patient don't have TB unless he is Rajnikant himself. I won't rush giving TPT to all my patients, especially in high incidence zone, because I practice in a very high burden area where I get 51% of primary pre-XDR TB, primary DR TB, and many of them are pre-XDR in them. So there are many concerns in my area to give TPT. So I don't know of the other sites where the incidents are low. Maybe challenges would be less on their part. I don't know. I cannot comment on their part maybe right now. At least in my area where there's really high incidence, I cannot dare to give TB unless I'm rest assured. And being rest assured is next to impossible for me. So don't know.
Yeah, Radha Munje ma'am, if you are online and you can tell us any take-home messages, or you would like to tell us something more about it. Is ma'am there? Is she able to connect?
Ma'am, if you're there, please. She's there.
Yes. I'm there. Can you just put it in?
Yeah.
I'm there. What I really feel that for both the arguments, it's too early to know because we ourselves have yet to generate the data which is needed. One thing. Secondly, about the concerns of developing drug resistance. Anytime if your TPT is effective, we are always going to have less number of people with breakdown disease. And hence the number of patients or people needed for you to study about the development of drug resistance would always continue to be low. It's not because a particular study has happened with 1,000 cases, right? It's always going to be. So we need more and more data. And we all, I think we should all agree that it's too early to introduce a policy. First thing. Second is, whatever may be the policy, we should have first a better test to diagnose latent tuberculosis. That is important. When we talk about active and when we are talking about TPT, we have to know which patients are to be treated, which people or persons have to be treated with TPT. Right? Do you want to treat all household contacts, or you have a test and treat policy where you first test, you look for presence of latent tuberculosis, and then you decide to treat that particular person for latent tuberculosis? That is important. And then comes about the single drug, about which we all have agreed that we would not advocate or support a policy where a single drug is being used for TPT. But perhaps by the time we meet again and discuss on the same topic, we may have other guidelines with more than one drug, or like the drug like rifampicin, which is being used but which is not made available all over, but is only in the study mode. We would have more evidence, right? That is what I want to say. I have nothing against the concerns raised. Concerns are valid, but these concerns can be either justified or refuted only when we get enough data of those particular category of patients, right?
Ravi, anything you would like to mention?
I tried to convince a lot of people, sir. I end up deconvincing myself only in the whole bit. So all I can say is be very justified wherever you advise it. That's all.
You don't change your mind because Amita did not mince her words, okay? You change your mind only if you are convinced.
Well, she used the word crime. Now, using the word crime is a very clear message which she has given. So it's ringing in my brain now.
So I'll tell you something. I just feel we have to be very honest to ourselves. We have to be honest to pulmonology. And I just feel that when, we all have a good voice, all of us are doing good work. If none of us are convinced, I to feel we should really be a mass crusade and make the government take away this recommendation. Because poor people, unsuspecting, unassuming people are the ones who are going to suffer. I genuinely feel that everybody agrees, whether you all want to openly say it or not. The alternate day dots gave rise to MDR-TB. Yeah. The standard blanket regime of MDR-TB has given rise to XDR-TB.
At least I'm going to raise a voice.
Yes, no, because I'm so happy. And I think we owe it to pulmonology, we owe it to TB, and we owe it to ourselves, yeah. I mean, we worked so hard to reach this level. We've not reached this level just to agree and please people. What's the big point?
Yeah, I agree with it. Absolutely. So, because I think you should take the lead and form a charter where we can perhaps have a signatory or a link, and we are going to have a discussion. It's not a fight. It's not at all going to be a war.
It's all about right and wrong, the concerns.
It's about an exchange of ideas where we come to a proper discussion and a conclusion which can be beneficial for everything without worrying about what could be the consequences. And those consequences are not minuscule consequences. They are going to be like a watershed movement in the history of tuberculosis. I mean, when we talk about Mantoux test, today also I gave a talk in the morning. I said, Mantoux test, please don't do that to consider tuberculosis. I told my doctors, my students, my friends, and today evening I am discussing about if Mantoux comes positive, then we should start with isoniazid or rifampicin. So we need data, we need robust data, we need to have a lot of...
Sorry, just a moment. Let me add. Yeah. It's not only the TPT which may help in diagnostic LTPI, but many new tests are coming up. Yes. And perhaps by the end of year, we may have a good test which would distinguish between, which would be definitely able to guide us towards latent tuberculosis. And treating latent tuberculosis is our objective. Our objectives are not all household contacts. Our objectives are not all contacts of a positive case, right? So first we have to look what criteria would evolve, and then we would look into the evidence which comes with it. Like what evidence has come, then on that particular evidence, what criteria do we have, and then perhaps by that time we would not have even a single drug PPT recommendation, because you know that the guidelines are changing so fast. We need lot of evidence. For example, you, me, Ravi, Amita, we all agree that we don't want to give this drug. Why don't we just have a opinion of other household contacts who come to you? Make a study, come out with it, make a recommendation that people are not willing to take. You make a recommendation that many learned people have gone into reading into the science of everything, and they have their own doubts about it. They are not convinced and they are not willing to take. See, anything and everything can be changed. अगर ये evidence नहीं है तो वो भी evidence नहीं है. You create an evidence. You have all the facilities for that. You have a background. You have skill, and what should I say? You have intelligence to create that evidence, which is a true evidence. I mean, you are not creating it. It's a true evidence. You are bringing it into light. So many things can be done. It's not only a voice, but it's going to be.
If we talk about Radha, yeah, taking it forward to what you're saying, honestly speaking, we've studied 1050 patients. Actually, it should have been a randomized control study. 1,000 people who have contact with sputum AB positive patients in the house are not given INH. Other 1,000 people with contact are given INH. Follow them up and see how many actually develop active disease. Because as I said, I can't remember 10 people who have disease, who got sensitive TB in the family. So just because people didn't get disease doesn't mean INH has worked. Half of them must be INH monoresistant and their relatives have not got disease with INH. So the thing is that what you study of 1050 is actually not very acceptable. Because whenever
I agree, that is what I'm saying. That is what I'm saying.
COVID also came out, when the recovery trial was out, why do we respect it? Because they had people as randomized control. Nobody wants to take arbit numbers of ivermectin HCQ because it is not a randomized population. Your recovery had randomized study everywhere. So how can we actually say that of 1,050, so many people didn't get so INH work? Did we even prove that those people had INH sensitive disease to begin with?
So these facts or these no. Yes, ma'am.
See, what I was saying, that is what I said, Amita, that first you have to look at the whatever is available and what is the background given.
What I'm saying is what is available is not good. Radha, I'm saying what is available.
Listen, Amita.
Amita, let her complete.
Listen.
Yeah.
As of now, even you won't treat any patient who is diagnosed of TB without ruling out resistance, right? So, abhi jo evidence generate hoga about which I am talking, we would always look at those cases who are DSTB and those who do not have INH resistance and nor at least resistance to the drugs which can be identified on first line and second line NPA, and then only you would offer. And then you would have a data where people who have received prophylaxis and those who have not received prophylaxis. And that is how it should be done. वही मैं अभी बोल रही थी ना, that we need to generate data and not create data. We have to generate data in a proper way, and then only we can come out with recommendations.
The only worry part is, ma'am, that it has already come into the
exactly.
guideline, and now we are.
नहीं, देखो, लेकिन see, science is always a soft science. It's dynamic. It's always changing, and something in which you strongly believe. If you back it up with other evidences, your word is the golden word, right?
So I think we are going to be
and whenever we have such scientific discussions, I think we should go out with something good on it. I mean, we don't approve of a policy, but we approve that more data is needed, right?
So at the moment we are all
Salil, for example, if more data is generated and the data comes that there are more than n number of say 100 cases or 1,000 cases who had tuberculosis being household contact, they had breakthrough infections, and then the resistance rate was less than 2% or 3% for INH, whatever. Would we not believe it? We would believe it. So what we need now is there is a missing link between the data which is very old and is being used and not in a methodical way in which we would have liked it to be. And here we have a policy which we feel is not strongly supported by evidence, right? So that is, we should go out with on a note that what is needed. When we refute something, we have to look at what do we really need.
Yeah.
No, so ma'am, I think what we will do is I'll just try to explain. What we are concerned is, of course, we know that this is not going to be the best way out to give a prophylaxis in the format which has been, because we feel it is not enough to really be sure and give us a concrete, robust data. But unfortunately, without that robust data, which as Amita pointed out, it has already been rolled out. And then we are discussing, is it really going to be useful or not useful? So our concern was that before getting this into perspective, had we have had enough studies, enough data, different centers involved, and then understanding and then getting convinced, it would have been a perhaps more acceptable, and we would have got a better outcome out of it. Is it really worthwhile to do this TPT or not? That would have been the first question mark. And here we are having that to come, and then we are questioning, is it now worthwhile? So that's the discrepancy, and that is where the problem is. But anyway, we take it as on a positive note. As Amita said, every change may not be good, but change is the only constant in this world. So we have to try to amalgamate everything together, take the wise words from our seniors and give some wise words back to them, and and have a good night's sleep for everyone. But I think it has been a really wonderful session, and I wish Vikas takes the lead and Amita also joins him in going ahead and trying to tweak this kind of policy.
Yes, yes.
Yeah. So I thank CCI for getting all these eminent panelists, Dr. Munje ma'am from the airport, Dr. Priyadarshini ma'am from the airport, Dr. Amita from her musical layer, which is she's sitting always, Dr. Ravi from Indore, Vikas has been at Gujarat today, right, Vikas? Delhi, sorry, for the Stop TB campaign. So from different parts of the country, people have come together, and that's the beauty of CCI. So I thank the organizers, Dr. Krishna and his entire team, and of course Cipla, for having these educational programs going on. So thank you so much.
Before logging off, since today it was the prevention therapy, so next discussion would be, we are going to move towards now management part, treatment part. The next session, next Thursday, it will be about understanding the drugs and principle of making the regimen of tuberculosis for DRTB. So let us understand about in and out about drugs first. What are these drugs? What are the actions, mechanisms of actions, and how do they work? That's it.
Okay. So today were fireworks. Next time it's only music. Okay. Bye-bye.
Salil, I would like to in particular congratulate you. You were just so fantastic. You actually guided the entire discussion in a very nice way, you know. And it was really very, very nice that you made sure that everybody was really, you made it extremely interesting.
Thank
And thank you.
Can I keep this back?
Thank you.
Bye.
Bye.
Bye.